Hello, welcome all of you again. This time the title is Medical Humanities and Disability. Well, you may be wondering, we are doing a course on disability studies and why medical humanities? Well, so far you may have observed there is some tension between the medical model and social model, and I have indicated many times that both the models are required. But we need to have a critical understanding of practices of medicine and even health. For that reason, there is a robust field as old as disability studies, and I guess it has very close linkage with disability because disability is a very important human condition. So, understanding medical humanities uh, with some attention to disability, therefore, is very helpful. Well, there are controversies about the name itself, medical humanities, because some say it is a very restricted term, focusing on just medicine and doctors. Some say health humanities will be a much larger and comprehensive term. We have here Dr. Shubha Ranganathan from IIT Hyderabad, who understands both medical humanities, medical anthropology, as much as disability studies. It's quite a privilege to have her here on Skype. So let's start straight away. Shubha, uh, can you tell us about yourself and then we'll go on from there? I mean, your work in medical humanities and so on.
Hi, Hemachandran. Nice to be here again. Thank you very much, first of all, for inviting me to join in this conversation about two fields which I'm just beginning to learn about actually. So, Hemachandran has been quite generous, in his introduction to me, but I am just dipping my feet, so to speak, in the waters of both disability studies and medical humanities. Um, but I do think that medical humanities as an approach, both as an approach as well as a discipline, does offer, quite does have quite a lot of promise for looking at questions of pain, suffering, illness, disability through a more holistic and interdisciplinary perspective. So my own background, my training has been in psychology, and I've been working on health and mental health. But I've also been working on health and mental health from a more anthropological perspective. So medical anthropology would be the closest field that sort of describes the kind of work I do. Um, so I do think it's really important to have more of interdisciplinary work nowadays. So bringing together, psychology, literature, anthropology, sociology, cultural studies, all of these in looking at questions of health and illness and disability. So and given that disability studies also is framed by the social model of disability, which looks at not just a biomedical approach, it's very important to have these conversations.
Great, Shubha. So let's begin with the term medical humanities. What does it comprise, Shubha? Uh, what are its broader persuasions and how does it inform many things like illness, patient's experience, doctor-patient relationships, and much more? How does
Yeah,
it inform?
yeah. So I think, I mean, the origins of medical humanities actually, it does sort of, historically, it does go back to the field of the practice of medicine, not just the disciplinary field, or the knowledge base of medicine, but more of the practice of medicine, with the recognition that medical education needs to also include topics uh, which are not directly from biomedicine, but which are related to engaging with patients. So, for instance, topics on communication, right? Topics on representation of illness, or representation of the body in art, in literature, in sculpture. So medical humanities as a broad term, I think it encompasses um, it brings together various disciplines, as I said, and it's really a way of understanding what it means, to be human, what it means to deal with questions of illness, or healing, or suffering. So in that sense, much of the medical humanities courses typically have their origins in medical schools, and their aim is to inculcate a sense of the social science and in the practice of medicine. So to train their doctors in how do you engage with people who have different belief systems regarding the body, or regarding pain or suffering, um, as well as how do you understand the different kinds of social contexts in which you are practicing. So it was more of, I would say, with the intention of in a way humanizing and the practice of medicine. But medical humanities since then has moved beyond that, has moved beyond the medical school as well, has moved beyond medical curriculum and medical education. And yeah, but I would still say that largely many medical humanities courses and programs are sort of related to medical schools.
That seems more or less obvious because in the first place, as you rightly said, it was meant to humanize medicine because uh, in the later half of the 20th century onwards, I think um, arrival of huge technology industry like MRI and ever increasing influence of pharmacology and pharmaceutical industries. Medicine has become more of a corporate enterprise, and
Right,
doctors increasingly are trained to focus on just pathology of the body and not the experience of illness. So that in
right,
some sense dehumanizes the entire enterprise.
right.
Even astute students get dissuaded from listening to patients when they become doctors. So in a sense, I think, as you say, medical humanities, in some sense, bridges the gap between medicine as a science and as an art, maybe an art that deals with human experience.
Yes, absolutely. Yeah.
Uh, so this is being the origin. Medical humanities has both the sides. In itself, it can function as an independent field where people like you and me and I mean I can, for example, dig into a literary archive in Indian scenario and come with its
Mhm.
own interpretations of illness, caregiving, health, suffering, and so on.
Mhm.
Or one can design curricula in such a way it helps doctor training, medical training or medical education, where
Mhm.
professionalizing caregiving and treating becomes fully uh, maybe becomes holistic so to speak.
Right.
Uh,
Right.
so, well, going from there, Shubha, um, how does it actually work in the um, medical field? Let's talk about, for example, dehumanizing. Um, so,
Mhm.
how does it humanize things? I mean, we understand that reading literature and the novel, we become sensitive, but one can just read them and just forget. I mean, how does it even help a doctor in
Well, I mean,
human?
at a very sort of, at a very basic or obvious level, I would say understanding the diversity of human experience
Hmm.
across the globe. So there's no one way of being ill or being well. There's no one way of defining even what is illness and what is health. So I think even the recognition of that heterogeneity and that diversity is something which would be important. So for instance, if you're looking at something um, like um, when do people go to a doctor or go to a clinic for reporting a symptom? If you're looking at health seeking behaviors,
Hmm.
looking at people accessing health services,
Hmm.
people would engage in health seeking behavior if they see themselves as having a problem, or if they label something as a problem and potentially an illness. But again, how in some contexts, people might not even see. For instance, let's take something like pain,
Hmm.
right? Which is such a inchoate kind of experience,
Hmm.
um, very vague, very difficult to define, very subjective,
Hmm.
and not measurable, right? It's the one physical symptom or physical category really, which can only be identified. There is no known diagnostic test for it. Can only be identified by the report, a
Or
subjective report of a
patients.
patient.
Correct.
Yes,
Hmm.
and of course, pain tolerance varies. In some contexts, people might see pain as a normal part of everyday living,
Correct.
and in some contexts, people would not report it. So, for instance, I have a student who is working on pain, and she's working on chronic pain, and she went to a government, a doctor in a government hospital recently,
Hmm.
and she described her project, to him, and he said, you won't find those kinds of patients here. People don't come here for chronic pain. They just take, whatever over the counter medication they can get their hands on, and they sort of get on with their lives. I mean, they don't necessarily label a problem as chronic pain, or even see that as something to get uh, to access help for. But you change the class, you move to an upper class spectrum or a middle class spectrum. You move to a middle caste, or upper caste. You move to a different social demographic, and you see a lot of pain clinics and pain centers and Ayurvedic treatments for pain and all kinds of service providers. So I think medical humanities at a very practical level is about giving the knowledge um, to doctors, and a lot of this knowledge comes from medical anthropology about the diversity of human experience. And then I would say another very practical kind of application is about communication. Is really
Communication.
about language.
Oh,
Yes.
okay. Can you explain
Yeah. So
more?
doctor
Yeah.
communication.
Yeah. For example, communicating pain. Is it a tingling pain or a um, stabbing pain?
Yes.
or a deep pain. There are lots of 100 varieties of pain.
Yeah, I mean, so not only in terms of the kind of words which are used, but even, for instance, in terms of how much to talk. So like in the Indian context, the field of medicine is also very hierarchical.
Mm.
So it's very clear, the status of a doctor is different from a status of a patient. It's very clear who directs the conversation. It's very clear that patients respond, patients answer.
Mm.
They do they don't direct the conversation. They do not steer the conversation in specific ways.
Mm.
And that, if patients are not asked the question, they may not report. Or if patients think that they are expected to say yes, that's what good patient behavior is, they might do so. So I think even understanding, the sort of the psyche of, the specific patient pool that one is working with,
Mm.
and then learning how to communicate.
Mm. So, in some sense, first medical humanities can aid cultural competence and also empathy and bringing empathy and communication role together in medicine training.
Mhm.
Um, for its own sake, how does it work, Shubha? Generating knowledge. For example, your student went to um, government hospital, but what if
Mhm.
your student digs up folk narratives and come up with
Right.
explanations on illness and grandma's medicine and so on? What does it do to medical humanities?
It changes the idea of what is medicine also. It changes the idea of what is healing. That healing also is not necessarily, the biomedicine dominated kind of healing which we understand. Healing is not just the sort of, the absence of cure. I mean, this was in one of the papers I have written.
I'm going to come
Uh,
to that soon.
yeah. So, I
Yeah.
mean, I brought it up because even the notion of cure is something um, which has usually been defined from a very biomedical frame,
Mm.
right? But healing healing may not necessarily overlap with cure. I mean, it may extend, it may be beyond that.
Mm.
So I think in terms of so there are contexts in which patients don't just want to get treated; they want to feel wholesome. So
Mm.
that, and then you have the whole wellness movement, which is really about propagating that, right? Not about being well, not just about being well and not being sick, but about having a full and complete sort of life, about being better than well. And then there's some contexts when, for patients, it's not just about whether they get well or not, but about the process, the path to healing. They don't want that path to be an unpleasant or a painful or a troublesome one.
Yeah.
Process of treatment and healing to be something which involves them, or which where they understand what is going on. I mean, it can go the other way as well. There may be some patients who don't want to know anything about their disease. They just want to get rid of it. But I think, so it's so even to impart the idea to doctors that there is not necessarily one perfect way of doing things as a doctor. I think that is something which is really important. That there is no black and white.
Most definitely, because existential questions don't have yes and no answer. They cannot
Mhm.
fit into objective type answers, or nor they can be narrated in 5 minutes of patient-doctor interview. It looms large, and uh, imparting that knowledge to both the patients and doctors and the health system at large is an important task that we all have for now, and hence the relevance of medical humanities as a field, I guess. But bringing this disability component, how does it work, Shubha? Because see, on the one hand, we have feminist scholars usually talking about caregiving in the private sphere. There are those who talk about access to health as human rights for people with and without disability. There are others who get into phenomenology of illness and disabilities and together also, like Carol Thomas, who talk about impairment effects. I mean, she said in the social model, don't delete the challenges the impairment poses, because it is real. It is very, very, very real. So,
Absolutely.
yeah. So now, where do we fit this whole different kinds of labels? We'll talk about labels, then real situations. Like you did mention about pain, you did mention about suffering. I would add illness and disability. Then where will it go? How does it go?
Yeah, so when it comes to disability, I think the social sciences, their contribution to disability studies is also very central. Recognizing that what is really needed in the understanding of issues of disability is a social science perspective. And I mean here, so in the social sciences, there is the material discursive perspective, which is really about arguing that there is a material context to social phenomena. At the same time, there is also there's also a discursive context. So taking a very extreme radical constructivist position that all kinds of all kinds of experiences or all the categories are socially constructed or are sometimes can be equally damaging, even while be enabling, because it may not necessarily recognize a very real material context in which people are living. So you think of, caste is one very good example for that. Right?
Which one?
Caste or
caste.
Poverty.
Yeah, correct.
For instance.
Yeah.
Right? So, I mean, it's all very well to sort of argue that, and one could, from a radical constructivist, or, argue that caste and poverty are all at the level of discourse, at the level of language, and they are constructions of the mind, but that doesn't recognize the very real conditions of living that people are housed in. So the material discursive perspective in the social sciences bridges, both, and that is something like that is important even in fields like disability studies, or like, for instance, in fields which I work in mental health, as well, where you have a similar sort of situation of some extreme position that there is absolutely no such category as mental illness, or the idea that mental illness is a myth, or is just a construction, or is just a means of social control. And while there is an element of truth to it, I would say to overgeneralize it would be to sort of negate or deny the kind of suffering that people go through, and ultimately I think so from disability studies, the own learning for me, like which especially the field of psychosocial, the area of psychosocial disabilities and mental health has taken it, is to recognize the voice of the person, and how people choose to identify themselves. So one person might choose to identify themselves as as disabled. Someone might not choose to you know use that label. One person may choose to identify or to oneself as having an impairment, so in a very medical sense. But for me, I think what is important is to sort of allow a plurality of different different options or different approaches.
Great. So, see, doctors, now let me talk about doctor's dilemma now. See, on the one hand, doctors know a lot about human body, and they have a box of labels, maybe a big box of labels connected to the bodily functions and non-functions. And on top of that, they have a commitment for their professionalism, maybe do no harm, something like Hippocratic oath. So I'm here to treat my patient, and the person
Right.
who is sitting in front of me is my patient. So I myself have experienced this. Once I enter, the doctor knows that I am visually impaired, and um, if I go with a eye pain, then it is all about um, instead of focusing on the pain, the focus for next half an hour will be about focus on curing my blindness. And even if I insist, no, it can't be, doctors somehow, because of the commitment for their work and a commitment for curing, then his or her um, sympathetic attention, real genuine attention, will be about curing. So, given this, but a person who is hardened in disability rights would see that as a, I would call it even insult. But somebody who is as much committed, who can understand doctor's predicament, may be more understanding. So I am just giving a real life conversation
Yes.
in a doctor's uh, consulting room.
Yes. Absolutely. I mean, how doctors choose to define the problem
Mm.
may not necessarily be in sync with how patients choose to, define the problem. I mean, in the field of mental health, this happens all the time.
Mm-hmm.
When, let's say if a person who is diagnosed with schizophrenia complains of some kind of, physical pain or physical symptom, a psychiatrist might be very quick to assume that this pain is also somehow psychogenic in origin, or the label of schizophrenia or mental illness sort of over defines the patient for them, just as in your case the label of disability over defines your identity. Um, so I think even learning to listen, therefore, doctor patient communication is not just about doctors talking and speaking, but about really learning to listen. And I think that is something that's very important.
It seems like a very difficult task. I mean, in some sense, we expect from doctors which is not actually practiced by other professionals. I don't find in our own professions, teachers not necessarily teach from a student's point of view. There are aggressive PhD supervisors, and just who talk about rules and not the person. How are we going to really? This seems like more like an ideal rather than a doable situation. Is that a fair description, Shubha?
Are we placing too much of a burden on doctors?
Yeah, I mean, maybe I said that.
Yeah, I mean, that's how I read it, at least.
Yes.
No, I don't think so. I mean, I do agree with you that this is some empathy, the qualities that we're talking about, qualities of listening, qualities of empathy, qualities of care, right? I mean, these are required in a variety of other service professions also, and increasingly, the best service professionals are those who are able to imbibe and
these qualities,
those qualities.
Yes.
So I don't think it is an unfair burden on doctors. I mean, the response would be as to why should doctors be exempt from that?
Definitely.
Why? I think also it's about in medicine, in at least as practiced the traditional way, has very set ideas about what is a success and what is a failure. Successes and what are the failures of medicine. So someone refusing, treatment for a condition that they could possibly cure, might be seen as a case of failure for a doctor. I mean, if the person chooses to do it for whatever reason, either religious belief or cultural beliefs or practical reasons, whatever, it might be seen as a case of failure in medicine. Even when as social scientists we know that treatment and cure is not the only or even
goal,
perhaps the most important thing. So it's really about bringing the shifting the language from cure to care, while recognizing that care itself cannot be defined in a singular way.
Great. The humanities, medical humanities are in that context, care context, talking about something like narrative medicine. What is that, Shubha? What is narrative medicine?
So I mean, narrative. The narrative perspective is all about the power of language, isn't it?
Okay.
And about stories. It's about how we understand our lives as storied constructions. So we live out stories in our lives, which means that there are characters, there is a plot, there is some idea of what kind of ending might be there. There's a sense of action and movement. So stories are about things happening to people. Stories are not just descriptions. They're not like factual descriptions of what is tuberculosis, but it's about someone having tuberculosis and how it affected his or her life and what they did and what happened to them. So stories are really about that. And I think in medicine,
it is even more important.
Yes, absolutely. We talk about illness narratives.
Correct.
That especially when people are affected by some serious kind of disturbance or disruption in their normal life story, there is a tendency to then ask the question, why me? And there's a tendency to weave a story around that, which is your illness narrative.
I could recall this nice autobiography, Shubha, Dr. Paul Kalanidhi's When Breath Becomes Air. He was diagnosed with stage 4 cancer and was a leading neurosurgeon, and he had only a year to live, and that triggered him to write that remarkable self-reflective. I mean, he wrote to live. He wrote so that he can discover his meanings in the final stage of his life. I mean, existential drive to write. That's what prompted him to write such a very nice autobiography. So what you said now about narrative medicine, we are storied reality, and we are all made up of feelings, and these feelings cannot be just generated or captured by statistical analysis or blood chemistry, blood report. We tell ourselves, and caregivers tell us something, and you only need to visit a patient who has recovered and just still listen to him or her, and that immediate caregivers, how they recall the battles lost and won. You know, it's all
Yes.
about their spirit to of resilience and much more. You know. Well, Shubha, that makes me slowly move to your work in medical humanities. I would say it's a very fine work of cultural psychiatry. Um, well, I'm defining it that way. I'm sure you define it much more in a nuanced way, because even 10 minutes ago you said mental illness, for example, cannot be defined just by a label. It is because it is also an experience. It is also a spiritual, it also connects with one's spiritual universe, one's well-being, one's past, one's future. One only have to listen to Reshma Valyappan's interview a couple of weeks ago in our course. The way she defined her condition, schizophrenia, it's not there in any book of that is defines schizophrenia. You know, for her it is all about her commitment to multiple urges, sensations, voices, and commitments that come from inside. That kind of definition I never heard anywhere.
Yeah, because it's a first person narrative.
Correct.
So in the field of mental, I'm cutting in here,
Sure,
to
sure.
sort
Go
of
on, go on.
the thought that's running in my head before I lose it. But like in the field of, even the mental illness, the expert perspective has a certain definition about what is schizophrenia. But of course, the experts are not schizophrenic until now. And it's only with until now, where now with the user survivor movement and people like Reshma arguing that we are also experts by experience, given that the doctors, the psychiatrists, the clinical psychologists, they don't know what it feels like to see visions or to hear voices or to have compulsive urges, for instance. But people who experience a condition do know. I mean, they know some of it, and that kind of knowledge is equally valid, if not more. It's equally important, if not more. That is what the experts, by experience perspective, really argue. So, so do we need a user survivor movement in the field of medicine broadly in India? I think so. I think for too long, patients are not seen as consumers. They're not seen as people who are using and accessing a service. And so there's
Instead,
then the whole
instead, what are
question
they
of
seen as?
patient rights.
What are they seen as, Shubha, instead?
Recipients. I think they're seen as recipients,
Okay.
in a sense.
Hmm.
You know, the, so not necessarily as having rights,
Hmm.
but getting benefits.
Hmm.
They're seen as recipients who are, getting benefits either from the state or from the system. Even if it is private practice, right?
Hmm.
There is no concept of patient rights, right? I mean, it's almost you're made to feel as if you're obliged to the medical system for getting the services you require, even
Hmm.
if you are in private practice and you're willing to pay and all of that. You still have to wait in a waiting room for a long time. You still have to. You are still told, what you need to be doing or how you should be doing it. I don't think you're taken on board.
Your
I
perspective
think,
is not taken on board.
yeah.
Okay. Um, uh, tell me about your. Tell us about your work with um, on field, Shubha. Mahanubhav sect, and you have you've written good many amount of articles on field work. You went to those temples, lived there, participant observation, and yeah, maybe you can begin there. Maybe I can chip in whenever I need some clarification.
Yeah. So my work began with an interest in looking at extreme states, and I was looking at women's experiences of trance and possession in healing temples and healing shrines. So I was looking at women who went to different kinds of healing sites because they had some kind of difficulty which they attributed to a case of possession or black magic, and or a case of being possessed by ghosts, being a victim of black magic, and they went to temples or sites which are seen as having a power to you know to heal these kinds of cases.
Hmm.
Uh, and part of the healing process in the temple also involves going into a trance.
Hmm.
I have done field work to try and understand the narratives around possession, around illness, around healing
Hmm.
uh, context, um, and I think it has very important implications for even telling us, as to what do people define as, when do people label a problem as a problem? When do people, so how do people define what is illness? And what is important? What do people look for when they look for healing?
Hmm.
So what I found is that for many of the women, that it's also about accessing a space which is which is very accepting, which gives them a kind of freedom and a space which they otherwise cannot necessarily access in their everyday lives,
Hmm.
which breaks them from the mundane and the monotonous routine of their everyday responsibilities,
Hmm.
and gives them a space to just be. And it also builds a community, with a community, a network of fellow sufferers, so to speak,
Hmm.
in ways which otherwise are not necessarily directly accessible to people. So, um, So pilgrimages, I mean, staying in healing shrines, they offer a range of opportunities for women in certain contexts, to sort of broaden their experience, broaden their life.
What about, I get this point about their seeking, say, get into possession, and they seek temple rituals. You, Sudhir Kakar, and many have detailed documentation about such states of mind and spiritual experience. But modern medicine would dismiss this in one statement as, or one word as, superstition. So
Unscientific.
yeah, on scientific basis, or even rationalists, our own humanities people, many may also see it as um, um, a source of exploitation of poor people. So, how do you deal with such contradictions when working on such things for yourself as a academic and working from the field of medical humanities? So, was that a clear question, Shubha?
Yeah. So
Yeah.
I think yes. I mean, I understand the question.
Okay.
I think that kind of dismissal of these kinds of local healing practices as superstition or as unscientific or irrational comes from the notion that there is one way to do science, that there is one kind of science which is or should be universal. But when you come from the perspective of anthropology, medical anthropology, and you start from the presumption that there is not necessarily one way to be human or to experience humanity, then you you do not categorize behaviors or practices as either rational or irrational, or as either scientific or superstitious, but you look at them as practices, you look at them as beliefs. And so in my own work, whenever this question did come up, and I had to address it, even at a personal level, the only way I found to do that was to understand that this is asking the question of whether people are really possessed or not, whether people are really in a real trance or in a fake trance, whether it's a case of faking or it's a genuine case. That asking the question of which one is it, that is not the right kind of question, right? From the vantage point or from the perspective of the individual, right? How they define their reality. So when you recognize that there are multiple realities, and if you live in a universe where there are ghosts, there are jinn, there are people who use black magic, there are things like that, if that is something which is conceivable in your universe, it's very possible for you to define yourself as possessed and to go into a trance. Whereas if you live in a in a disenchanted world,
like seeing body
right?
as just a machine, made up of parts. Yeah.
Yeah, I mean it's like the place of religion,
No,
right?
I'm
You
talking
live,
about disenchanted world,
yeah.
outlook. Yeah.
These are the same kinds of difficulties. These are the same kinds of issues which came up with the Enlightenment,
That's right.
right? When religion suddenly had a very different kind of status from its previous
Dominant.
pedestal kind
Yeah.
of position,
Correct.
because
Correct.
Yeah, so if you live in that kind of, rational, disenchanted universe, then you are not going to go into a, trance. You're going to see things as very unreal, and that is your reality, and I'm appreciative of that kind of reality as well. I don't necessarily like to even use terms like spiritual or spiritual healing, or because it almost seems to sort of glorify a certain kind of reality. I don't necessarily, so I rather than thinking of spiritual experience as something which is necessarily or a higher level or plane for their non-spiritual experience. I mean, I'm not necessarily sure that that is also true, because the reason I say this is because now in the field of health itself, you have this additional dimension of spirituality, and that health, the WHO definition of health. It's not just physical or mental, but also spiritual health, which um, I think may again not necessarily hold true for everyone, right? Um, yeah. So I think my own work sort of pushed me to sort of be very deeply appreciative of the different kinds of realities that people are inhabiting, and the problem often is that when there is crosstalk, right,
Correct.
between doctors and patients, or between um, survivors and service providers. So that is, I think, where medical humanities can come in.
So, I mean, eh, introducing medicine and health services to contexts of healing, experiences of healing, I mean, differential experiences of healing, and formative um, concerns concerning caregiving, care receiving,
Hmm.
all that seems to be um, uh, can certainly make medicine wholesome. It seems
Hmm.
that's the goal of medical humanities, and that is where disability studies scholarship can also benefit and offer, because um, it can see disability studies certainly sees disability more than a broken disability is more than a broken body and broken mind. So similarly, this wholesomeness can
Mm-hmm.
add, but you add a very important dimension. While working on this many healing traditions, you don't necessarily privilege one over the other. You merely aim for democratizing the validating many kinds of human experiences, and that can feed into health services, including doctor training. Uh, um,
But
yeah, can we put it that way, Shubha?
yeah, I think that's a very good way of putting it.
You know what? We are just nailing 1 hour there. Karthik really
Okay.
alerted me. Very nice talking to you, Shubha. Um, hope listeners will really like it. Thank you so much for coming on Skype.
Thank you, Hemachandran. It's a pleasure.
Take care. Bye bye.